because we have a lot to cover. All right. Good afternoon, everybody. Welcome to the first meeting of the Cost Growth Target for 2026 to 2030 work group. I'm Sarah Bartleman. I use she, her pronouns. I'm with the Oregon Health Authority, and I'm going to be facilitating today's discussion. So, um, work group members, please come on camera if you don't mind, and if you can, technology-wise, we're going to do introductions in a minute. Today's meeting is being recorded. Today's meeting is also being live captioned, so you can turn that on through Zoom if that would be helpful. The chat is enabled, so committee workgroup members, please feel free to drop questions or comments in the chat as we go. We'll try to answer them as we go, but we might not, but feel free to use the chat today. And then, of course, housekeeping. All materials are also on the website for today's meeting, and the recording will also be posted on the website. Right. Melissa, let's go to the next slide. Did I miss anything? Yeah. Please be careful with muting. We'll call you, we'll mute you if anything's going sideways, but um, please be aware that you're in a public meeting. Okay. Well, next slide. So today's agenda, we're going to do introductions because this is the first meeting of this work group. We're going to talk about the charge and the process that we're going to follow for this work group. And then we're going to spend a little time orienting to the cost growth target program, the cost growth target and cost trends in Oregon to date, and how the cost growth target was initially set. So in some ways, this meeting is going to be a lot of me talking, and I apologize for that, especially for those of you that have been with the cost growth target work since 2019 and will know a lot of this. But before we get into our substantive discussions and actually start looking at data and economic indicators in future meetings, we really wanted to make sure everybody had the context of where we came from and how the target was initially set in 2020 so that we brought all of that coming into this conversation. Next slide. So let's go ahead and do quick introductions. I'm going to call on the workgroup members. We're going to go alphabetically down the roster, alphabetically by first name. And if you would please share your name, your pronouns if you like, and your organization and role. I'm going to drop a link to the roster in the chat just in case folks haven't seen that, or so you know what order we're going in. But that is where we're going to start. So Abigail, are you with us starting with A?
Thank you so much. Abigail Kershey, she, her pronouns, Oregon Nurses Association, legislative and political organizer. Thanks for having me.
Thanks. Blaine? Brian?
Hello, everyone. Brian Beringer, Oregon Medical Association. I'm the exec, he, him.
Charlie?
Hi, my name is Auden Friedman. I'm sitting in for Charlie Fisher today. I work with Osberg's High Value Healthcare campaign. I'm a campaign associate with them.
Charlotte Flood is not able to join us today, but will be at the second meeting. Cliff? Daniel?
Yeah, hello. Yeah, hey, good afternoon. So I'm trying to get off mute. Cliff Indargo, he, him pronouns. I'm from Peace Health. I lead the payer contracting functions.
Thanks, Cliff. Daniel?
Hi, I'm Daniel Porter, he, him. I work for Legacy Health and Payer Contracting and Population Health.
All right. Deb? Deb, I see you and you're on mute. All right. Deb, if you want to drop your intro in the chat, I'm going to keep moving and we can come back if we figure out muting. Denise, are you here today? And Eve?
Hi there, Eve Gray, she, her pronouns, Director of Health and Human Services for Lane County.
Thanks. Heather.
Hi, Heather Rowan-Horst, CFO for Sante.
James.
James Parr, Executive Vice President of Operations and Chief Financial Officer for Salem Health Hospitals and Clinics.
And Jen Lewiscoff.
Hi, Jen Lewis-Goff, Head of Government Relations for Kaiser Permanente Northwest. And apologies, I'm having some tech issues, so I'll try to get on camera.
And Jen Johnson. Justin. Okay. Keaton.
Keaton Miller, I use he, him pronouns. I'm an associate professor of economics at the University of Oregon, where I specialize in competition in healthcare markets.
Kirsten.
Hi, Kirsten Isaacson, Research Director with Service Employees International Union, SEIU, Local 49.
Craig.
Good afternoon, Craig Anderson. I'm a Senior Vice President and the Chief Actuary with Moda Health.
Larry. Okay. Lisa. Mullen.
Moleen Patel, Senior Vice President for Finance and Treasurer at OHSU.
Melissa.
Melissa Dom, she, her pronouns. I'm the CFO for Providence Delivery System in Oregon.
Michelle. Right. Paige.
Paige Frederick, she, her pronouns. I'm the Chief Population Health Officer at the Portland Clinic.
Paul.
Hello, Paul Harmon, he, him pronouns, an actuary for commercial pricing at Regents Blue Cross Blue Shield of Oregon.
Rick.
Rick Blackwell, the Government Relations Director for Pacific Source here in Oregon.
Russ. Russ, if you're talking, you're muted. Okay, maybe come back or put your intro in the chat. Ryan.
Hey, good afternoon.
Sorry, Sarah.
Oh, go ahead, Russ.
Sorry, Sarah and group. I'm Russ Schust. I work for Optum. I'm the Senior Director of Healthcare Economics. I'm in transit, so I'm having technical things with, I'm on my phone, but trying to figure out the laptop too. So apologies.
Thanks. Ryan.
Hey, good to meet you, everybody. My name is Ryan Tuthill. I'm a policy manager with Oregon Business and Industry covering healthcare. I'm looking forward to working with y'all.
Sabrina.
Hi, everybody. Sabrina Riggs. I'm the contract lobbyist for the Oregon Independent Medical Coalition.
Sierra.
Sierra Canfield, she, her Director of Public Policy for the Hospital Association of Oregon.
Tara.
Hi, apologies, I can't be on camera. I'm in transit, unfortunately, today, but Tara Harrison, I'm the Government Affairs Director for Providence's Health Plan.
Thanks. And do we also have Tara Thatcher on today? Okay. Timothy? All right, and Trent.
Finance for Samaritan Health Plans IHN, also representing Samaritan Health Services.
All right, great. Thank you so much, everybody, and thank you for the lightning round. I know that a lot of you know each other. We've talked to a lot of you in cost growth target conversations, so a lot of familiar faces here, but thank you all for coming together for this work group. Okay, next slide. So let's talk about why we're here and what we're charged with doing. Next slide. So one single charge of this work group, we are single purpose, and the charge is to review economic trend data and make a recommendation, so a work group recommendation back to the Oregon Health Authority on what the cost growth target should be set at for 2026 through 2030. I want to be really clear that OHA will make the final decision on the cost growth target for that time period. This work group is making the recommendation to OHA. Next slide. So again, just some level setting, couple things that are in scope and out of scope for our conversations over the next 5 meetings. Things that are in scope, determining what the cost growth target should be for 2026 to 2030. Part of that includes deciding or recommending if the target should change. So should there be a different target for each year or for some of the years within that 2026 to 2030 period, or should it be the same value for all 5 years in the period? The last bullet that is specifically in scope is a recommendation on how and when the target should be revised in the future. So we'll talk about this more later in the meeting, maybe a next meeting. Unlike some other states that have a specific statutory requirement or directive where their cost growth target is revisited annually or on some other cadence, there is no directive in Oregon at this point. And so we are going to ask this group for a recommendation on what the process should be for the subsequent 5 years, and if 5 years is the right interval or if something else should be. Things that are not in scope, cost growth target data collection and reporting. Those conversations are handled through the cost growth target technical advisory group. They're also handled through cost growth target rulemaking when applicable. Also want to be clear that other elements of the cost growth target program that are in statute and or rule or both are not in scope for these conversations. There might be things that are flagged that we'll put on a list and maybe we'll punt over into some of those conversations, but just want to be really clear that this work group has a fairly narrow scope and single charge. Any questions or comments about scoping? Okay, next slide. Let's talk about how we're going to do that. So we are also on a pretty fast timeline. We have 5 meetings that are on the calendar between now and the end of November. We are planning to hold those 5 conversations and then have the work group submit the recommendation to OHA. OHA will issue a final decision on the target for 26 to 2030 by the end of December. We're aiming for December 19th. So that is the timeline. We want this landed by the end of the year. Next slide. So because this is a pretty tight scope and timeline, we've done quite a bit of work mapping out how to stage this conversation. So this is what we're thinking we'll cover in each of the 5 meetings and how the conversation will go. So today, as I said, we'll talk about the charge, the process, the program, the trend, talk about how the cost growth target was initially set. Meeting number 2 is next week. So it's going to be real. These 2 are real back to back. In fact, we'll be sending out materials for Tuesday's meeting later this afternoon. So next week, we'll talk about cost growth targets in other states, how they're set, what value they're at. We'll talk about what the economic indicators are at a very high level, just an introduction to them. And we'll talk about a couple of key questions that can help shape the approach. The 3rd meeting is November 5th. In that meeting, we'll bring Oregon-specific economic data for those economic indicators for your review and consideration. And we'll begin discussing what potential targets could be given those economic indicators and those inputs. And then meetings 4 and 5 are a little looser at this point, depending on how conversations in meeting 3 go. It may be that the group reaches a recommendation very quickly and does not need meeting 5. Recommendations can be finalized fairly straightforward. Here's the target done. But we're leaving them open to see what happens, what comes up, particularly in meeting 3 as sort of the key discussion meeting. Questions, comments about that?
Hey, this is James. One quick question, if I may. So I couldn't find the hand up button because we don't use it.
Please go ahead, James.
Okay. Will in the economic indicators section, will you be considering, because there's lots of economic data, economic indicators specific to healthcare? For example, we've seen the largest spend Medicaid CCOs in our community get tripled, 3.4% increases. And I just want to make sure we also see a lot of providers in our communities suffering financially currently. And I hope that that is factored in amongst, I'm sure, the plethora of other data.
Yeah, great question, James. And so let me respond to that. And then Melissa, I see your hand. So the way we're currently set up, again, because Tuesday's meeting's coming right up, we know there are some specific economic indicators that this group, you as a body, are supposed to look at because that's what the previous recommendation said. Revisit these economic indicators. So we have a starting list, and that's what we're going to start with on Tuesday. But on Tuesday, we're also going to ask you, what else should we be looking at? And if there's anything not on the list that needs to be added, James, to your point, if there are other data points we need to pull in, we want to hear from you what those are next week so that we can bring that data forward for the meeting on the 5th for consideration. So yes, so keep that in mind as we go through, as we send out the materials for Tuesday's meeting, as we talk about those economic indicators, think about what's missing and what else you might need to have to inform this conversation. Melissa.
Yeah, appreciate you. And you may have the same answer or similar answer on this as well. When we talk about the cost growth targets in other states, there are some measurable differences in their approach. So will that be some of the nuance, not just, looking at the percentage and where they've been and what they're going, but there are some, considerable differences in those programs. So wondering how relevant or how we're thinking about understanding what those differences are.
Given that I have mostly drafted some of those meeting materials already, I can say that I didn't go deep on that in those differences. I think when we present and talk about that on Tuesday, we can bring more of that into the conversation, if that would be helpful.
Thanks.
Yeah, no, it's all rapid iteration, so I appreciate the questions. I want to make sure we bring you what would be helpful for the conversation. Other questions about the meeting arcs and topics? Okay, next slide. Let's talk just a little bit more about process. Oh, Melissa, did we skip a slide? Yeah, decision making. Okay. So this is a large group. I think we have somewhere between 35 and 40 members. I'm not remembering what the actual count is, but we are not going to try for consensus, I think, because we are only having 5 meetings and want to move through this. So we are likely going to be developing this recommendation through majority vote. We want to document minority perspectives and include that in the recommendation back to the agency. Will help make sure that your conversation is captured as accurately as possible, but setting the expectation that we're probably looking at some votes and we'll be looking to you as work group members to make proposals and respond to them amongst yourselves. We're looking at adding some tools, whether that's some survey tools or embedded electronic voting into upcoming meetings to help facilitate that, whiteboarding, polls, whatever that might look like, just to set expectations for that conversation. Next slide. And another process piece. These are public meetings. They will be recorded and posted online, as I've said. Each work group meeting is scheduled for 90 minutes long, and we are not scheduling a public comment period on any of the agendas. That does not mean that people can't provide public comment or that you as work group members can't submit written comment about this process. You can absolutely do that. Members of the public can absolutely provide comment. We will post all of that comment online, make sure that any comment that comes in will direct you to it so you see it. But we're not going to hold the sort of standard OHA open mic public comment time on meeting agendas for this process. Other questions or reactions to these process pieces? Oh, and I should have said, we are expecting, we'll take public comment all the way through the end of November. So much of that will inform your conversations as you meet over these 5 meetings, and then anything additional that comes in after the final work group recommendation will be factored and brought to the agency for the agency final decision. Okay. You're a little quiet. It's making me a little nervous. Everyone good so far? Okay, thank you for the head nods. I appreciate it. Okay, let's talk about some of the context on the cost growth target 101. So again, I acknowledge that many of you know this. Many of you have probably given this presentation in your own organization or something similar. So bear with me. We're going to make sure we're all on the same page and then get to the how the cost growth target was set in 2020. So next slide. Next slide. What is the cost growth target? Very basic. The cost growth target says currently that total healthcare spending in the state should not grow more than 3.4% each year. This is a year-over-year measure, and it is a total cost of care measure. Next slide. At a high level, the cost growth target program every year collects data, measures, and analyzes what is driving healthcare costs, what healthcare cost looks like, what healthcare cost growth looks like relative to the target, and publicly reports. Our work over the last couple of years has really been focused on that right side of the circle. And we've had some conversations, although they're growing this year, particularly driven by the Oregon Health Policy Board, to begin identifying those opportunities and strategies to slow cost growth and to implement them. So that's things like the new Affordability Committee and Industry Advisory Committee that some of you are also participating in. Next slide. So I think there is still, we've been doing this work for a long time. We've been having these conversations since 2019, sometimes even earlier, but there's still a lot of confusion about what the cost growth target is and is not. So I want to restate a couple of things for the record. So the cost growth target is a target for tracking and evaluating. So it's a measurement tool. It lets us know how we're doing, what's happening with spending, and what the long-term overall performance of the healthcare system looks like from one very specific metric. It is a measurable goal that ideally is catalyzing public and private action to improve healthcare affordability and access. It is also a method for enhancing transparency so that market participants, you all and your peers, policymakers, and the public can understand what is contributing to higher healthcare costs. And it is also a long-term framework to track and identify unsustainable spending growth and opportunities for improvement. Next slide. What the cost growth target is not is it is not a cap on total healthcare spending, prices, premiums, or payments. It is not a measure of internal costs and operating expenses for either health plans or healthcare providers. It is not a punitive measure. Cost growth above the target alone does not trigger accountability measures. There are some acceptable reasons for cost growth above the target and an annual process to determine that. And it is not a single solution. It was never going to be a single solution, and maybe there was some overselling that happened earlier. Really, it is a tool to provide key information and data that can inform some of those other policy initiatives to improve affordability and access. And again, ideally, it is spurring and catalyzing action within your own organizations to help address some of those key cost drivers. Sierra, please.
Yes, thank you. So while we're here and the first mention of accountability measures, I just wanted to mention that as I reviewed the slides before this meeting, I noticed that there is no mention of the performance improvement plans or the financial penalties that are scheduled to start later in the program. And so I just wanted to make sure to bring that up and encourage you to include that in the background information as well.
Okay. We can certainly provide some more information as part of follow-up about what that is for people to ground on. But at a very high level, there are accountability measures for the program. They are in statute and they have been on a phased implementation. This year is the first year that an entity, a payer or provider, could be subject to a performance improvement plan for exceeding the cost growth target without an acceptable reason. So we are just on the edge of rolling into that next component of the program's accountability measures. Sierra, is there anything else that you think is immediately relevant for today's conversation?
Just want to make sure that that came up in the context of this slide. Thank you.
Great, appreciate that. Okay, let's go to the next slide. So Oregon was the fourth state to establish a statewide cost growth target program. There are 8 states that currently have a program. There are several others that are continuing to explore or explore similar policies. And with the addition of California's program, 1 in 5 people in the country are in a state that is covered by or subject to a cost growth target. So let's talk about why and some of the reasons why we're here. Next slide. Next slide. So we all know the United States is an outlier on healthcare spending. This graph and variations on this graph, this is healthcare spending as a percentage of gross domestic product. US is at the high end of these 10 countries that have been studied, and the growth has just continued to outpace in pretty much every way that this has been measured over time. Currently, healthcare spending as a percentage of GDP is predicted to exceed 20% by 2035. Next slide. Healthcare costs have been growing, so these data are the annual increase in national healthcare spending as reported as the percent increase from the previous year. You can see that consistently it's been above 4.4% nationally. There was a particular spike in 2020 that represents the federal spending and provider relief for the COVID-19 pandemic. And you can see that since that 2020 spike dipped to 21, we've been back on a pretty sharp increase. I think everyone on this call is aware that we're looking at and we are expecting to see higher increases when we add 24, 25, and potentially even 26 into this data. Next slide. If we pull the most recent projections that are available, this comes from CMS's Office of the Actuary, and they do an annual measure of national cost growth, both actuals and projections. Projections for 2028 to 2033, cost growth is projected at about 5.3% a year. To put that in perspective, GDP growth is projected to average 4.1%, and that 5.3% for healthcare really flattens out across the payers. So Medicare's growth is projected at 7.4%, Medicaid expenditures at 6.2%, and private health insurance or commercial spending is expected to grow by 4.3%. Next slide. The next couple of slides are some graphs from the Peterson KFF Health System Tracker, which is an incredibly helpful resource to catch up on any of the national data. And so one of the questions is, isn't this just inflation? Yes, that projected growth, isn't that just a reflection of inflation? And generally, while inflation is also increasing, healthcare, medical care growth is outpacing that. So between 2000, sorry, I almost said 2000. Between 2000 and 2024, the price of medical care, which includes services provided by providers as well as insurance, drugs, and medical equipment, increased by 121%. In contrast, the prices for all consumer goods and services, so pretty common measure of inflation, rose by 86.1%. Want to note, this is data through 2024. We do plan to look at more current, sort of as current as possible, when we bring data in meetings 2 and 3. So acknowledge that the pressures have continued to increase and that the economy and inflation and other economic indicators are also changing rapidly. Brian.
Sarah, is that green line what we all commonly refer to as medical inflation number, or is that something different?
Yes.
Okay. Thank you.
Okay, let's go to the next slide. So we have one more graph here out of the Peterson KFF tracker. So this is looking at the cumulative growth in various costs. So employer health plan premiums are that top line, the green line with the greatest growth over the last 10 years or so. This graph also breaks out inflation a little more specifically. So inflation, rent, food, and overall, and puts wages in the mix as well. So this is the premium side of the equation. It's not all of it. Again, acknowledging that there are lots of different indicators, but just making the point that we are seeing continued, sustained, pick a word here, growth in healthcare in a variety of comparisons. Next slide. As many of you know, as we've had many conversations about this before in the state, these high healthcare costs lead to many negative impacts, including people delaying care, difficulty paying their medical bills, using up their savings to pay medical bills, and bankruptcy as a result of those medical bills. Melissa, please.
Yeah, just thanks, Sarah. Back on the other slides, but we don't have to go back. I just think one of the things maybe as we look next time, the per capita spend per state, and maybe in particular the starting places of those that are on the cost growth target that have cost growth targets would be helpful to understand and include. Looking at national information is good. Our cost growth target does not include traditional Medicare. And those rates, as most of us know, the total spend is growing because the population is aging, but not necessarily that the fee for service rates are raising at the types of rates that we're talking about here, along with Medicare Advantage as well. So spend is growing, potentially utilization, but also just the population. So total spend, of course, in that segment looks different. I think. And so that would just be helpful, maybe some context as well, as I know the starting place for Oregon is different than other states, and that would be helpful context rather than just looking nationally, but having both lenses.
Yeah, thank you for that reminder. I don't always look at that one because that data also comes from CMS Office of the Actuary, and they only update it like every 6 years or 7 years or so. And last time I checked, they had not updated it. So let me go see if there's new data. I can bring the old data, but I just want to warn everybody
And
that
I
that
feel
data's
like
old.
Kaiser Family Foundation does have some of that, but I don't know what they're using. So,
Okay.
thank you.
Last I checked, it was all the same source. They were just pulling it through. But I will look into it. I hear you. I think that's a good indicator to add to the list. Okay. Next slide just provides a little bit of data. This is something that we have summarized. This was in our impacts report from June. So again, just looking at some of the experiences that people in Oregon are having as they are struggling to pay their medical bills. Okay, let's talk about how we got to a cost growth target. So back in 2016, we were having essentially the same conversation as a state. We were looking at the same graphs. We were talking about the United States as an outlier on healthcare costs. At the time in 2016, especially relative to other states, Oregon was experiencing some of the fastest healthcare spending in the country. The 2009 to 2014 data, which is the like mini slide here on the bottom left, we were the fourth highest growth rate in the country. We are no longer, just acknowledging, and to Melissa's point, that has changed in the last 10 years, but at the time, we were growing very rapidly. The private sector growth in particular was growing, and prices in the Portland metro area in particular were high and being identified in a number of studies and analyses as a concern. That conversation in 2016 and sort of that atmosphere led to a joint legislative task force. Next slide, please. So in 2017, Senate Bill 419 established the Joint Interim Task Force on Healthcare Cost Review, and that group was specifically charged with studying the feasibility of creating a hospital rate setting process. That was the tool and the policy approach that the legislature identified as this is what we should do as our solution to all of these challenges in healthcare costs growth that we're facing. The process that the task force studied was modeled on what the Health Services Cost Review Commission in Maryland studied. And the task force was asked to assess the potential impact and feasibility of the Maryland model, and if not feasible, consider alternate models to accomplish the goals. The task force realized pretty quickly that the Maryland model was not going to be feasible for Oregon for a variety of reasons. And some of you might have actually been on that task force. Like, Kirsten, were you on that task force? Yeah. So it pretty quickly realized that that was not feasible and that we needed a different model. So the group studied several other states and what they were doing, several other policy proposals, and ultimately landed on the Massachusetts model, which was a healthcare spending benchmark, a statewide target for the annual rate of growth based on total cost of care, and with a real big focus. And I think, Kirsten, please jump in to add any context that I'm missing, but I think there was a real shared value at the time in this conversation of shared accountability, that there was not a single entity responsible. It wasn't the payer's fault, it wasn't the hospital's fault, but that the cost growth target would promote that shared sense of responsibility and that everybody would be doing their part towards a target. And an acknowledgement that this was a long-term conversation, that this was not something that could be sort of a switch flipped and healthcare costs would be lowered overnight, that this was about setting a trajectory and a framework or foundational work for long-term affordability solutions. Kirsten, others that might have been around for this 2017-18 conversation, any reflections or remembrances that you would add right now?
I think you captured it really well, Sarah.
All right. I'm happy to link to the report if anyone actually wants to read it. It's interesting and depressing that in some ways we're having the same conversation now, almost 10 years later, and saying, okay, what's the model? What should we be doing? What do we need to have this work for Oregon and to improve affordability? But again, just some of those initial values that led to the cost growth target as a model were specifically total cost of care, shared accountability, and a long-term strategy. So, next slide. The other reason that Oregon ended up moving forward with a cost growth target was because our public programs were already subject to a cost growth target. So the Oregon Health Plan, or Medicaid, and then PEB and OEB, our public employee plans, were already required, both through our 1115 waiver and through some statutory and budgetary restrictions, to limit per person cost growth to 3.4% a year. 3.4% first came around because of Medicaid. That Medicaid waiver conversation looked at what the projected cost growth was. Again, that CMS Office of the Actuary projections, and at the time it was projected to be 5.4% for the next 10 years. And Oregon agreed to a 2% bending of the cost curve. So that's how we got to 3.4%. There were so many questions trying to recreate some of that modeling, but it really was based on what the projections were at the time and a 2% bending of the cost curve. At the time, compared to what the cost growth was supposed to be, there was quite a bit of projected savings in general fund expenditures for the state. And there was a sense in the legislature in particular that the cost growth target program and the cost growth target work would then spread the model and the potential for savings outside of the public programs and into the private market and benefit the rest of the state. Next slide. So those task force recommendations led to Senate Bill 889 in 2019, which created the cost growth target program. That Senate bill also established the cost growth target implementation committee and charged the committee with a list of 14 specific things they were supposed to weigh in on. Again, I know a number of you participated in that implementation committee and are familiar with this work. And in developing those recommendations to guide the program, that included setting the initial target, reviewing those initial economic indicators and deciding on the approach and that 3.4% of being the target for statewide. The implementation committee also was charged with developing accountability measures and a recommendation for that. Those accountability recommendations led to a second piece of legislation in 2021, which codified the accountability measures. And then after that, we had the advisory committee for 2 years for continued guidance around implementation. So this has been a deliberately staged, long timeline. Sierra, to your point earlier, the accountability measures have been phased in. They are now here. But this has been a conversation that's been building for a long time. All right, I'm just going to give you a few more details on cost growth target background, make sure we're all on the same page. Next slide. All right, next slide. I want to be really clear. Oh, yeah, there you go. That the statute as written says that the cost growth target applies to all payers and providers. That is the language, and that is really broad. So, next slide. One of the things that the implementation committee did in 2020 when they were developing their recommendations was figuring out how to operationalize that language. And so, as a result, we apply the cost growth target in Oregon at 4 levels. So we measure statewide. We measure statewide at the market level, Medicare, Medicaid, and commercial. We measure at the payer level. And there are two thresholds for payers. So to be included in the program and to be required to report data, payers or insurers have to have at least 1,000 covered lives in Oregon. To be included in public reporting, we have a higher threshold than that. For payer data, we include Medicare fee-for-service or traditional Medicare, as well as Medicare Advantage, Medicaid fee-for-service, as well as the Medicaid coordinated care organizations, and the commercial insurers, primarily the fully insured market, although we do have some self-insured data as well. And then the fourth level is provider. And this was where the implementation committee spent a lot of time talking about who is a provider, what do we mean by provider, where do we draw the threshold? And so to be included in the program, we're talking about provider organizations at the parent company level. We're not talking about individual clinicians. We're not talking about individual practices. And those provider organizations must have at least 10,000 attributed patients. So payers attribute data to provider organizations based on a variety of ways. And provider organizations have to have a certain number of attributed patients to be included. So there are lots of provider organizations that fall below that threshold and are not included in cost growth target public reporting or accountability. So want to note that there's been some, what's the word I want, discretion applied in that how the all payers and all providers are operationalized in the state. Okay, next slide. What are we measuring? Next slide. Primarily, we're using two measures, and this is what's being compared to the cost growth target. The first measure is total healthcare expenditures, or THCE, and this is a measure of basically all dollars that we can find that are flowing in the healthcare system between payers and providers, as well as the net cost of private health insurance, or essentially the admin costs for health plans and other costs. So we also are rolling in spending happening at the Portland VA. We're including healthcare spending at the Department of Corrections. We're including behavioral health spending that is sent directly to the counties and is not flowing through an insurance plan. So we're trying to have a as representative as possible understanding of how much we are spending on a per person basis. It is calculated and reported both in total dollars and on a per person basis. Denise, yes, absolutely. The slides are already posted online, and we'll send out the link again for folks to see them. And Sierra. Sierra, you're on mute.
Thank you. Is this from the 2025 report, this slide? Just to clarify?
Yes.
Okay, and then it's my understanding that the validated provider data for the 2025 report is not actually going to be released until late October. So I guess in the meeting schedule, did you allow any time to review the validated provider data and see if there are any shifts based on that as well?
The validated provider data does not have an impact on this data that's on the slide here. It does not affect the statewide results. The validated provider data, we expect it to be published, the provider performance relative to the cost growth target, we expect it to be published by the end of October. So yes, it'll be in the mix before the committee, sorry, before this work group has meetings 3, 4, and 5 and the discussion there. I don't have it built into the work plan for sort of scheduled discussion. I think we can certainly send it out and encourage you all to take a look and make any notes. I don't know that I think it's worth a detailed presentation, but maybe after we look at the next couple slides, you can tell me if you feel otherwise. Melissa?
Sarah, I'm sorry to just bring this up. When we talk about total healthcare expenditures and total medical expenditures, this is allowable claims data, but it does not represent actual medical expenditures, and we take into account financial assistance that's provided by providers.
These two measures, both total healthcare expenditures and total medical expenditures, which is a subset, are the claims data that are included in there are based on allowed amounts.
Right.
Correct.
Thanks.
I want to be clear that they include claims payments and non-claims payments. but they do not reflect if there is, in fact, a delta between what the allowed amount is and what the provider organization actually manages to collect in sum total from all payers.
Thanks.
Okay, the measure on the right, total medical expenditures, this is a subset. This is what we use for payer and provider level reporting. And it is the claims and the non-claims payments. So it doesn't include the admin and it doesn't include those other dollars that I mentioned. So this is a little bit lower on a per capita basis, but we also calculate that growth rate. Any other questions about the data, about what's included in either of these two measures? Okay. Oh, Keaton, please.
Thanks. Sorry, I was looking for the button. So just going off of Melissa's point, does OHA have the data necessary to compute sort of the cash flow payment basis for these numbers?
No. And this goes to my earlier comment about this is not a measure, the cost growth target and what we measure is not a measure of the operating expenses. So for some portions of the health system, hospitals in particular, OHA has very detailed financial reporting. And we do have a lot of insight into that, but not for all of the organizations that are subject to the cost growth target program. And back when the implementation committee considered what measures to use, there were a lot of conversations about what it should be based on. Should it be allowed? Should it be paid? And the general sense, folks who were involved in that conversation, help me if I say this wrong, but the general sense was that allowed would be more representative of the overall spend because it does capture the patient share of that, which is where some of the affordability challenges are coming from, even if there are instances, and certainly there are, where the provider does not necessarily actually collect all of that. Folks who are in the conversation in 2020, any other commentary on that? It was such a long time ago.
A whole different era.
I think it was Lisa Higgins who was sitting at the table for SEIU at the time. But that is as I remember that discussion and that dynamic, and it did arrive out of especially seeing, like, you had that chart that was showing the increase in high deductibles, and that trend line was already happening during that discussion. I just remember it was about capturing that patient portion.
Yeah, I think one of the other things to note, which, I know when we were first rolling this out, there was so much confusion about it everywhere, because this is really wonky, was that we're not measuring, you notice I didn't mention it, we're not measuring premiums. This is not, the cost growth target is not a measure of premium or premium rate increase. And every year when DCBS comes out with its annual approved rates, we have a whole round of confusion about, well, these rates are higher than the cost growth target. So we're not comparing premiums. Premium growth certainly is a factor, and it's what feeds into this, and it's the underlying component, but it's not what the actual unit of measurement.
Sorry, I can't find my raise hand button here. I'll look for it, but can I just ask a couple quick questions? One to that point is, why are premiums not factored in or looked at? Just because the cost of the consumer, a part of that are the premium costs, right? If let's say you're purchasing a plan on the exchange, the premium is a direct cost to you as a consumer. So, I
Yeah.
mean, if the state's approving 12% premium increases on the individual, I mean, why is that not evaluated in terms of a cost spend or cost target? Because it's not a spend, yeah.
Yeah, great question. And I'm laughing because I actually had a slide about this and I took it out and I shouldn't have. So the reason that we pulled it out, or sorry, the reason that we don't do that and don't measure that is because it's a double count. And so essentially we want to measure what's being spent on healthcare. And so that is how much is being paid from the payer, all the payers, not just the health insurers, but the government payers, the self-pay, whatever that looks like, to the provider. And that's the spending. The premiums are what's feeding in from a different source. And essentially, and I'm explaining this terribly, I apologize. If we include premiums in this total measure, we're double counting the dollars. So what we agreed on was that we'd have this total cost of care measure that looks at the claims, the non-claims based spending, and that separately, we would include other measures like premiums. We'd tease out deductible and copay growth, and we'd report on those things separately. But that's not what we're holding to the target. I will note that there are different approaches in other states, not in terms of what they're measuring. All states are using a total cost of care measure, but other states do have, Rhode Island comes to mind in particular, where they have an affordability standard explicitly in their premium rate review process, where they are saying, is the proposed rate, what is that relative to our affordability standard, in a way that we don't have in statute in Oregon. Cliff, did I answer your question?
Yeah, thank you.
James.
Hey, appreciate all the work that's gone into the preparation, putting it together. I'm pleased to be part of the work group. Only concern I have, and maybe you can allay my fears, Sarah, is the slide deck's very useful and there's some good graphs and information in there. It is one version of someone's view on healthcare cost growth. There are others out there. So I'll give you two examples, if I may. So, example, you know that the PEB 200% cap has avoided $700 million or $1 billion in costs. As a provider, it hasn't avoided it. It's just shifted them to non-PEB payers. So commercial payers, folks with a job, pay more, plus PEB and OEB pay less. And then there was a graph, an inflation graph in there that seemed to imply that somehow healthcare was increasing its costs beyond inflation. I think it would be good, and this goes to my point earlier, if you look at the underlying healthcare workers' inflation cost and the supplies that feed healthcare, for example, drug costs, etc., you'd get quite a different story where this is what the underlying cost has been. And the really big one out there that I think is missing, I didn't see in your slides, is patient acuity. Particularly through the pandemic and post, patient acuity has gone up at a much higher rate. Our patients are sicker now. And I think for us to truly have a complete view on what our cost growth target should be, those pieces of data should be in there versus this very traditional look at the US compared to other countries, we're much higher. I feel it's a very narrow view that may get us to the wrong conclusion, but maybe you can reassure me. Thanks.
Let me allay your fears, hopefully. So again, this is an intro and a grounding on where we've been. This is not the end of the conversation and the data that we're going to give to you or make available to you to have a conversation about the target. So again, next week, we will talk about some additional we will start talking about economic indicators, specifically inflation, specifically wage, and specifically income growth. Those are the three that the Cost Growth Target Committee said should be revisited explicitly. So we're going to start there, provide that data, and then we're going to ask you what else needs to be in this conversation. I've already got a long list of your comments from today of other things that need to be in that conversation, and we will look to bring that data to you for meeting 3. So I really encourage and value that you're flagging what some of those other points should be so that you can have a robust conversation. And I want to reassure you that we will do our best to provide as much of that data as possible to support the conversation. I know for sure we can talk about the supply and the wages and the underlying cost growth because that definitely fits. We've already pulled some of that because that's part of the inflation conversation. I think if there are other indicators that you'd like to see, I can't promise that we'll get them for Tuesday for meeting 2, but I can promise that we'll work on them for meeting 3. So please keep the suggestions and the requests coming. And yeah, James, no worries. I just, maybe I was not sufficiently clear that this was an intro and not the beginning and the end of the information you would have for your consideration. Cliff.
Yes, and since this is an intro, just to ground the conversation, in one of your earlier slides, you mentioned what it is not. It's not punitive, but then I understand there are financial penalties. So can you clarify the relationship to being non-punitive, but then having financial penalties? And I'm
Yeah.
sorry if I'm late to the party on that one, but yeah, just yeah.
No, that's a great question. And I'm going to acknowledge that my answer is going to be one story on this. And I think if you asked many people on this call, they might give you a different story on how these are tied together and whether or not they are punitive. So my perspective would be that when I say it's not punitive, I mean it is not an automatic, you're over the cost growth target. There is no excuse. There's no reason, and you're just automatically slapped with a performance improvement plan or a financial penalty. That there's no nuance to it, that it's a blunt tool. I think what I would say is that the process as we are hopefully implementing is designed to accommodate that nuance and to provide some flexibility and to say we understand, and this is in administrative rule, that there are reasons for cost growth that we as a state support. We know that one of the major drivers of costs in the last couple of years has been behavioral health spending, utilization, particularly on the Medicaid side, but also spilling over into the commercial market. That's maybe okay. That's maybe really in line with state priorities and where we've invested. And we're not going to be penalizing any payers or providers if the reason they're over the cost growth target is because of their behavioral health spending. Similarly, we're taking a really detailed look at prescription drugs. This year, we did a deep dive into medical pharmacy spending. We know that there were some big cost increases there. There were some new drugs entering the market. We want people to be able to receive those services and benefit from those treatments. We were not holding anybody accountable for that. So I think when I say not punitive, I mean it is not an automatic over the cost growth target, here's your penalty. It's that there's a process and that we're attempting to tease out what's really going on and provide as much of that information and talk to you all, the payers and providers, to understand from your perspective what's going on and what those drivers are. Does that help? Would any of the
Yes.
payers and providers like to provide an alternate view on that question?
Hey, Sarah, it's on that lovely note. This is Tara with Providence Health Plan. And I'll echo an earlier comment about the need to really be looking at patient acuity and how that just the utilization trends have been so much higher because of that acuity, and it causes cost growth. But it's cost growth that's really necessary for patient care. And it's a factor that's not within those kind of reasonableness factors that have been looked at. And so this is one area where it does feel like there's this kind of punitive hammer that we're trying to avoid while really just taking care of members and patients.
Thanks for that perspective, Tara. I agree that utilization is not a specific line in the administrative rules or in the sub-regulatory guidance about what is an acceptable reason for cost growth. But I will say that we've had many conversations this year in particular with payers and providers about what is essentially increased utilization. Longer hospital stays because of inability to discharge to step-down facilities is an increase in utilization. We've talked about increases in primary and preventative care. So it is in the conversation, but I will acknowledge that yes, it is also not, utilization by itself is not an immediate acceptable reason. I also, and this is maybe, we're getting a little more philosophical, and I wasn't necessarily thinking we were going to go here, but given these questions in this conversation, I really want to essentially frame up some of the tension for you and welcome thoughts on this. As a group charged with looking at the target, if we think about the target, whether or not you all actually do or not, as this is a goal, we're saying that this is aspirational, we're trying to meet this, there is an out. There is the process with an understanding that if we're over the target for a variety of reasons, there's an opportunity to dig into those reasons and to not experience those punitive effects. That out is designed on the back end. And in part, that was deliberate. The cost growth target is set fairly aggressively. 3.4% was ambitious at the time. It is still ambitious. Dropping to 3.0%, which is the current proposal, which we'll talk about in a minute, is even more ambitious. I think there's a tension, and I would really appreciate and ask you all to acknowledge that tension of if we are talking about, and we might very well be over the next couple of meetings, a higher cost growth target, and I think many of you indicated that that's a direction that you think we might need to be talking about, do we still need as many outs? Are are both of those levers equivalent and do they both move at the same time, if that makes sense? Right now, we have a fairly aggressive target with a lot of flexibility. If we have a much more flexible and I don't know, another accommodating target, a much easier to meet target that might be more in line with things. Does that mean that respectively we have less flexibility on the reason side? So I'm not saying, and I want to be really clear that that's out of scope. We're not getting into the reasons and revisiting the reasons list, but I want to acknowledge to you that as you're having a conversation about the target and making a recommendation, there are both sides of this process and they are in tension with each other. Keaton. And then
I think one thing that's a really good point to talk about it sort of holistically. And I think the one thing that would be helpful for us to consider, because there is a very limited scope to the decisions that this and recommendations that this group can provide, sort of what the downstream impacts of this would be. So, and whether or not OHA would prefer that we think about the rest of the cost growth program as a fixed object that we're interacting with, or is this something that's going to, continue to evolve, potentially informed by the recommendation that this group makes and the cost growth target that OHA eventually sets?
I think I'm going to answer that right now. I will take that back also and report back Tuesday if there's any additional context, but I will say that I think this group really should assume that the rest of the cost growth target is fixed. This is the lever that we're looking at right now. That doesn't mean that we're not going to look at other levers in other spaces and in other ways later, but right now we're looking at the one. Craig?
Yeah, Sarah, and thanks for all the presentation. I think you went through that really well. I think this might get at your question, but I was on the implementation committee initially, and then having lived through this for the last few years, I think coming out of the implementation committee, I think there was a lot of acknowledgement that we were all in it together to try to meet a 3.4% target. But recently that's not really factoring into a lot of the discussions between, say, payers and providers so much. So I would just maybe my advice as we move forward is that we do something that's realistic, that we can all get back together to think we're all shooting for something that's reasonable and realistic, as opposed to something that's, well, I mean, if we go to 3%, it's just not going to be, I don't think that's going to really factor into a conversation between payers and providers. It's very.
Oh, Craig, we lost your audio.
Productive because we'll just have the table and it's getting out of there. So that's
Craig, you're breaking up and we lost the last couple things you said.
Well, I think I got my point across just to try to set something that's realistic that we can all agree to and work towards. Thank you.
Yeah, I appreciate that. Any other comments or reflections here? I really appreciate the engagement in what I thought was going to be the sort of boring overview. So thank you. Okay, let's go through a couple more slides. I want to make sure that, again, everyone's starting from the same place and everyone has seen the most current data that the Cost Growth Target Program has reported. So the next couple slides are pulled from our June 2025 report. Next slide. So this is the growth in total healthcare expenditures for the last 5 measurement periods relative to the target. You can see that in the last 5 measurement periods as a state, we have met the cost growth target once, and that was, let's say, because of the pandemic. That is the 2020 drop in utilization that happened and the resulting drop in spending that happened. And since the 2021 rebound, we've been seeing a slow and maybe steady increase in the total healthcare expenditures measure. Next slide. If we break up that same data, this spaghetti-like chart is the same cost growth trend, but by market. So Medicaid in green, Medicare in red, and commercial in orange. Medicare was below the target in 3 of the 5 years. It exceeded in 2021 with that COVID rebound and again in 2023. The commercial market met the target in 2 of the 5 years, and Medicaid met the target in 3 of the 5 years. The blue line that is zigzagging kind of wildly is NCPHI, or the net cost of private health insurance. So this is the measure of administrative costs for plans. We do include it in total healthcare expenditures, but we break it out separately because it's really volatile, as you can see. And if you include it and sort of roll it in, it really influences payer cost growth and market level cost growth in a way that we think is unhelpful. So in our reporting, we tend to break it out separately. So essentially, you can see that when spending goes down, NCPHI goes up because payers are paying out less. I'm describing this very crudely. Payers, please feel free to jump in with any corrections that you'd like to provide. But essentially, when spending goes up, as you can see in 2021, NCPHI drops because payers have less in that bucket. They're paying out more of their premium collection. They're paying out more in the actual medical spend. So inverse relationship there, pretty volatile. Melissa, did I see your hand?
Yeah, I'm trying to get off mute and raise my hand at the same time. I think the other context that is challenging is these patients are not like the mix of the proportion of patients receiving care is not the same. So when we present it at 3.4%, or we say, Medicare met it, 2 of the 3 years, or 3 of the 5 years. Yeah. There's a much larger portion of spend happening by Medicare than there is by Medicaid or commercial.
Yes.
As far as those seeking health care, right? Kind of who's seeking
and on a per
healthcare
capita basis, the dollar spend is much higher. Agreed. And
so this is just another piece of the on the per capita, it looks different too. So it just is, this is really complicated stuff as we kind of think through.
Yeah. And
understanding
I think maybe,
and creating a general understanding.
And maybe I'm going to encourage you all to take a look at our June report. I will make sure you all have the link because we do break it out on per capita by market basis. So you can see it is true. Medicare spending is like twice as high. So valid point. And I think one of the things I've, I guess, taken to heart is that you have to sort of look at all of these and do we spend all of our time making sure that we've seen all of these? The data are there. We have them in the report and I encourage you to take a look. Rick, please.
Thanks. Do we know how these numbers track with regular CPI? Like how close is it to overall, like the larger inflation?
A meeting 2 question. We are pulling CPI data for meeting 2 and we're going to provide national CPI data on Tuesday and we'll provide Oregon specific trended against this on the 5th. Does that work? Okay. Paul.
Thanks. I guess on the NCPHI value, I guess I'm not sure where it's coming from. Like, do you have it? This we could follow up offline too, but what is the source for this?
Yeah, it's from the oh God, my brain just totally blanked. SHE reporting.
Okay, from annual statements.
Yeah, it's from annual statements.
Okay.
Okay. Let's go to the next slide. I want to talk about, again, this is just to give some context of what's happening. The markets are different. This is the average annual trend. I know a lot of you and many of your peers have talked to us about how having a multi-year perspective is important because there is so much year-to-year volatility. So these 2 sets of graphs show the average annual trend. Left is 2018 to 2023, so pre-pandemic included, and right is 2020 through 2023. More recent. So you can see that there is some variation. If we're looking back a little bit longer, we're doing better on average. Since 2020, our average annual trend has been much higher. Next slide. So actually, hold on, I'm going to pause there. Are there any other questions about the data? If people have questions, I'm going to encourage you to take a look through the annual report. Feel free to email any questions over in between meetings and we can try to answer them, but want to make sure people have some general grounding in what we have been measuring. And again, to earlier comment, the provider data is not yet included in the June report. The payer data is, the provider data was delayed, and we're hoping to have that out by the end of October. Questions, comments about the data? Okay, so last agenda item for today, want to recap how the Cost Growth Target Committee set the cost growth target back in 2020. So next slide. All right, so the Cost Growth Target Implementation Committee had 2 specific charges on their list of 14 specific things they were supposed to recommend. One was recommending a methodology to establish the target, including the economic indicators to use for that, and then establishing the initial target itself and specifying the frequency and manner with which the target should be re-evaluated and updated. And those were charges directly from the establishing legislation. Next slide. The establishing legislation also gave parameters for the target. So these are also going to be relevant for your deliberations. So keep these in mind. We'll come back to them. The target must promote a predictable and sustainable rate of growth for total healthcare expenditures. It must be based on an economic indicator, such as the rate of increase in Oregon's state economy or the personal income of residents. It must be measurable on a per capita basis, a statewide basis, and a healthcare entity basis. And side note here, there are definitely some things that are measurable on a statewide and per capita basis that are not measurable on an entity basis. And then it must be able to be reviewed and modified on a periodic basis. Questions about the criteria or the parameters? Sierra.
Yeah, so in looking back at our implementation committee report, I did notice that there wasn't the level of specificity that I see in some other states, and maybe you can tell me if I'm just missing it. For example, in New Jersey, they specifically state that their benchmark is a blend of 25% potential gross state product and 75% forecasted median household income. And looking through our materials, it didn't seem like we had any sort of a specific formula right that. And I just like that. And I just wanted to make sure that that is correct and I wasn't missing it in the implementation committee report.
That is correct. And I'm going to explain why in a minute. But yeah, absolutely right. Oregon's target is less, the formula or the methodology is less specific than some of the other states. And next, for Tuesday, we'll have a comparison of the other states as well. So next slide. So the implementation committee went through a process of three sets of questions to answer those charges. What economic indicators should be used? How should the economic indicators be calculated? And then how frequently should the target be reviewed and modified? So specifically, should it be adjusted at a predetermined frequency? When it should be tied to a different economic indicator, and when recalculation should occur? Next slide. So their process, they looked at how other states, and at the time there were only 3 other states, looked at how other states set their cost growth target. They reviewed how PEB and OEB and Medicaid had set their growth rates because there was that pre-existing work to build on. They selected criteria for choosing an economic indicator, and they selected 2 criteria. One, that it provide a predictable target based on an economic indicator, which they lifted directly from the legislation. And then the second criteria was that they would rely on an independent, objective data source with transparent calculations. So the original committee got into a lot of conversation about different economic indicators and where some of them come from. So, there's third-party forecasting entities that have a bit of a black box on how they got to their forecast. And there was a strong sense from the original committee that the source needed to be transparent. And then they considered a set of economic indicators. And for each of those economic indicators, they looked at essentially 4 or 5 questions. So, what is the indicator measuring? What message that indicator sends? Like, what is it saying that we're prioritizing? How it can be calculated, and then what the historic and forecasted trend for that indicator is. Next slide. So they considered 4 key economic indicators. One that has the overall message and goal of tying the cost growth target to the state's economy. So they looked at growth in Oregon's state gross domestic product. That's the state level equivalent of GDP. There are 2 ways to look at that. You can look historic. You can have a look back period of a certain number of years, and you can have a forecasted or a potential gross state product. They also looked at 3 indicators that would tie the target to the finances of people in Oregon. One was growth in personal income. The second was growth in per person wage. And the third was inflation as measured by the Consumer Price Index. Next slide. So these are the recommendations. This is where they landed. And Sierra, here's the key point of where it got squishy. So the implementation committee recommended that the cost growth target should be the same for all levels. So we should have one target, and that target is applied for the state, for each market, for payers, and for providers. Since then, I want to note that other states are maybe considering some different approaches on this. There's been some sort of evolution since 2020. California recently adopted a cost growth target specifically for hospitals, sector-specific targets, but original recommendation, one target applies to everybody. The cost growth target should be tied to an economic indicator that reflects the state's economy, adjusted for wage or personal income growth. When I went back and reviewed the implementation committee report, I was like, what did we mean by adjusted for? And really, if you remember these conversations, if you were in these conversations, the committee looked at all of the data, and all of the actual numeric values of those economic indicators were kind of triangulated in the 3 to 3.5% range. And the group said, we don't need a formula. We don't need to tie it. It doesn't need to be inflation plus 1% or gross state product minus 2%. We think we're just going to pick 3.4% and we're just going to ballpark it. So I want to be really clear, there was not a formula. It was a ballparking pinpoint and said 3.4% is the target. In part, I think that was really heavily influenced by the PEB, OEB, and Medicaid targets that were in place, and there was strong value in aligning with that. But also, all the economic indicators roughly came out in that ballpark at the time. I think there's a question about do they still, and we'll look at that in meetings 2 and 3. And I think there's also a question that we want to ask you for the next meeting is, do we want to keep that? Do we actually want to switch to a formula? Because all the other states except Oregon have a formula at this point. So 7 other states actually calculate it or have it directly pegged to an indicator. We're the only one who essentially looked at all the numbers and said, yeah, 3.4% sounds good. So be really clear about that. We don't have a formula. It was a deliberate choice. And so when I now think back on those conversations and think about the adjusted for wage or personal income growth, there was a lot of conversation with that committee about valuing that reflection of wage and income growth, but feeling like the economic indicators were all essentially converged enough that we didn't need to have a formula or an adjustment. 3.4% would cover it, basically. Craig, others, anybody want to reflect on those 2020 conversations?
Well, I agree with you, Sarah, that I'm gonna stay off camera because my system's a little laggy here, but I agree with you. We sort of defaulted my memory to the 3.4. Things seem to be centering around that. I think I might be making this up, but it seems like when you're tying something to a formula, a lot of the data is retrospective, and we're trying to set something for future. And I feel like we struggled with that a little bit because we need a plan for the future, like you're setting premiums or you're having discussion about contracting or some targets. So I think we need to consider that when you're looking at historical data, how you might interpret that for a future target.
Yeah, great point. And I think that was why the committee also looked at both historic and projected or forecasted. And we can do the same. We can look at historic and forecasted. And I want to also, Craig, you brought up a great point. The committee really valued the importance of that. We need to know what the target is and we need to know well in advance. And so the committee recommended that the target be set for 10 years, 3.4% for the first 5 years and 3.0% for the next 5 years. So this is our touch point to say, was that right? Should it be changed? But really, the touch point is, okay, let's finalize what it is for the next 5 years and also figure out how do we continue to provide that predictability and that looking ahead. And I could see, I really want to ask you, and think I put it on the list for meeting 4, like, do you want to recommend the target for 10 years? Do you want to say like it should be this for 26 to 30 and this for 30 to 35? I mean, you could. I think, is there value in that conversation? So I think we want to talk about that more in a future meeting.
Yeah, I remember that specifically because you do need to plan out ahead. I mean, I'm sure the hospitals are planning many years in advance. So, but as we've seen, things can change so quickly. So it's almost like we need a mechanism maybe to set something for a while and then intervene if necessary. I don't know. Maybe there's something there.
Yeah. And when we talk Tuesday about how the other states are doing this, there is a difference in how frequently the other states revisit their target. And I want to make sure you have that context and consider whether setting it once every 5 years is the right approach for Oregon or not. Is it responsive enough? And how do you, again, we're back to that tension, the tension between having that predictability and being able to plan for contracting and looking forward and being responsive to what's happening. Okay, next slide. We're getting close to the end here. So last bit of the original implementation committee's recommendations, a to be determined advisory body, so that is you are the determined advisory body, should review, and they called out 3 specific indicators that should be reviewed. And so that's where we're going to start in the next meeting by looking at those 3 things that they recommended be revisited. And then the last bullet here, after reviewing the data, the to be determined advisory body should recommend whether to keep the 26 to 2030 target at 3.0% or increase or decrease it. So that's where the charge is. That's the setup. That's where we're going to start the conversation on Tuesday. Keaton.
Is the only option increase or increase to one number for all 5 years? Does the policy space include it's one number for 3 years and another number for 2 years or something like that?
Yes, the policy space includes the flexibility for that, and that is absolutely a question that we want to ask you to weigh in on. I think we want to be able to tell people by the end of December, here's what the target is in each year between now and 2030. But if it's a different value in each year, I think that is completely up to you all for your recommendation. Rick, then Cliff.
Thanks, Sarah. Was there a reason that a formula approach was rejected by the implementation committee, other than it was just difficult?
I think, oh man, I can double check the notes. Those of you who were in the conversation, like if you remember, I think the other states had not gotten quite as formulaic at the time. And I think the committee didn't think it was necessary. I can double check that, but if anyone remembers differently, please chime in. And preview for Tuesday, I specifically have a question for you of, do you want to keep the approach of we're just going to pick a number, or do you want a formula? So that's on the table for next week. Cliff.
If you go back one slide, please. Can you just explain real quick, like, hey, should be tied to second bullet, economic indicators, so forth. How is that reviewed? What is the process for reviewing that to make it as concurrent as possible to changes in the economy? Like, for example, the COVID pandemic, right? Can you explain a bit about the process of that?
Yeah, and again, I think we're back to that tension that I was talking about a little bit ago, where the original committee said the target's going to be set and fixed for 10 years. So we have predictability, we have sustainability, everybody knows what it is. We can all message around it, we can contract around it, we can all align towards achieving this target. If there needs to be flexibility because of things that happen like a pandemic, which to be fair, in 2019, nobody said anything about a pandemic. That all came later. The flexibility of, okay, so there was cost growth that exceeded the target. why, and was it for a good reason, an acceptable reason, or not? And so right now, as designed, the flexibility is on the reasonableness side. It's not on, a group that comes together every 6 months and changes the target. And I would ask you to consider over the next couple of meetings, is that better? If you're a payer and provider and you're contracting, if you're an employer and you're purchasing, would you want to have a group that got together every 6 months or every year to look at the economic data and change the target? Like, how helpful is that relative to knowing what the target is well in advance and being able to plan towards it? I can't answer that for you, so I'm going to kick that question to the group. Craig.
Are you kicking it to us now or for next meeting?
For next time. Sorry.
Okay.
That was a
All right, I'll give
philosophical
some
kicking.
thought.
Yeah. Okay. Let's go to the plan for meeting 2 because we're just about ready to wrap up. So next slide. Again, you all did such a great job teeing us up and asking all of the right questions that I think we're going to have a really meaty conversation on Tuesday. So on Tuesday, we're going to talk about how other states have set their cost growth target, and we're going to do a really high level summary of how they all compare. I have a sort of a summary document that lists all the states and what they do and what their formula is and how many years they've got the target set in advance. So we'll be sending that out this afternoon. We also have invited Connecticut to come talk for a few minutes about their process. So Connecticut just went through this earlier this year. They convened an ad hoc group to specifically look at the data and revisit their target. Granted, their context is different, their statute is a little different, but they basically wrestled with these same challenges. And I've asked Alex, who's the director in Connecticut, to come talk to you and just share some reflections and some perspectives from having gone through that process. And I hope that that's helpful. Then I think, as I've been signaling, we have some key questions. Want to talk about the criteria for selecting the target. Should we stick with the current methodology or adopt a specific formula? Should it be based on the economy or the finances or both? Should it be based on other economic indicators? And then what economic indicators should we be looking at the data for? And so I think that gets to James's question and comments earlier, as well as some of your other points. So I want to, again, be really clear. We're modeling this conversation after the way the original implementation committee had it, where they had a conversation about values and sort of philosophical approach before looking at data. And that doesn't mean that you're going to make a binding decision and say it should be a formula or not, and then look at the data and say, oh, well, we said it had to be a formula and now we're stuck. But the original committee had really, I think, had a lot of value in having a conversation about these questions before they looked at the Oregon specific data to see what the numbers were. So that's why we're staging this conversation to say, let's have some key questions. Let's set some parameters. Are there other criteria that you'd want to add to the list? Connecticut added some criteria, and Alex is going to talk to you about that. And I think it's a really interesting process. And so want to have a little bit of a conversation about what matters to you before we look at the numbers and actually start coming up with a value. So I hope that all makes sense to you, or at least if it doesn't, you can live with it because these meetings are going to go by really fast and we'll get into the data shortly anyway. But that's the plan. Materials for meeting 2 are coming out tonight, tomorrow at absolute latest. There is some suggested reading, not required, but there are some things that if you want to look over, that might be helpful just for context that we're going to be suggesting. And otherwise, we will talk to you all Tuesday afternoon. Final questions, comments? Okay. Thank you all so much for your time. Really appreciate it. Talk to you Tuesday.
Thank you.
Thanks, Sarah.
Thank you.
Everyone.